Thank you so much, Lauren, for that introduction. It's wonderful to have everyone join us, and we're really excited as well to have a mix of different professions as well joining us, which is really great to see. So my name's May. I'm a GP who works in the Inner West, similar to Hester. And I've got a particular interest in mental health and complex chronic care, women's health and paediatrics, but I also work as an academic lead general practice at Hetty Higher Education, facilitating their Masters of Mental Health program, which Hester's also done as well. So, you know, just like Hester, we're both really passionate about this area. Including psychological care and motivational interviewing, which is why we're going to be talking today. I'll let Hester introduce herself.
Yeah, thanks, May. So I'm Hester. What May said. But in addition to that, I'm actually a fellow of the chapter of addiction medicine. So I have a specific interest in substance and addiction, but also chronic care and comorbidity with mental health and drug and alcohol issues. So we are perfect for doing this. We're going to have a conversation. We've got some slides to kind of make sure we stay on track. We're really keen for you to have some input. So put some questions in the chat. We will answer them. We want to make this as interactive and as informative and as useful as it possibly can be for all of you that have joined us.
Yeah, I'm going to reinforce that. Please ask us questions because we really want this to be really relevant for those who are joining us. And, you know, I think we could talk forever about this topic, but we want to make it actually useful for you. So, yeah, please let us know what you'd be interested in.
Fantastic.
So we thought, just to get a little bit of an idea of what you're interested in, we had a couple of polls that we thought we'd like you to engage with. So the first question that we have.
So May, oh yeah. Sorry, we just had the webinar. We just had our learning objectives. Got to talk about the learning objectives.
I've jumped.
But basically, it's finding out about trauma-informed care and motivational interviewing principles, and particularly in motivational interviewing principles, it's around identifying change talk and thinking about how you might apply this in your clinical setting. So how's that? Is that a good kind of summary of it?
I think it is a good summary, and I think what we also recognise that for some of you where motivational interviewing is new for you, if you are going to put this in practice, if you're going to leave here after tonight, the thing which is probably going to be the most helpful thing for you to start on your journey will actually be trying to identify what we're talking about with motivational interviewing and identify what that actually means in the consultation and listen out for those opportunities. Even if you're not quite sure what to do about it at the first stage, listening out for the opportunities probably is the most important thing when you start off in the journey.
Fantastic. But May, let's get a bit of an idea. We've got these two polls just to give us a bit of a sense of where you guys are at. Let's move to those.
So I think you all have downloaded the app. So Lauren, are you happy to be able to put the first poll on? This question is about asking about how confident you are using trauma-informed care. Okay, so we're just going to give you a moment to be able to engage with that. And you can answer it either as strongly agree, agree, neither agree nor disagree, disagree, or strongly disagree.
How's that going, Lauren? Have we got a good number of people that have responded?
Yes, we do. I'll just close that now and share the results.
Fantastic. Ooh. So we've got a few
Ah,
people who feel pretty confident, but quite a few who don't. And so that's 55, 70, nearly 80% of people who don't feel confident. That's brilliant. That's really good to know. We'll just go on to the next poll.
beautiful. So, oops, clicked on the wrong thing. So the next poll is going to be about how confident you feel undertaking motivational interviewing with your patients. So we're going to give Lauren an opportunity to action that. I was saying before we started that my son joins me on most of my webinars, but at least he's clothed now, whereas when he was younger, he wasn't.
How are we going, Lauren? We've got some results there.
Yep, they've started to come through. I'll give it just about 10 more seconds just to get everyone's answers in.
Fantastic. So a plan from understanding where you guys are coming from is that we can really tailor the conversation that we have tonight towards what's most helpful for you. Okay, so we've got a bit more confidence with motivational interviewing. So it's just over 40%. Fantastic.
Ah, that's really interesting. Great. Although, you know, we've got equal numbers of disagree to agree, though, noticing. Yeah.
Yep.
So,
Yep. So, I mean, the way that I take away from that is that this is a group who are a little bit more confident in terms of motivational interviewing. So I think, May, let's go to the whole trauma-informed care, which is your area of expertise, and give us your gems.
okay. So initially we thought we would use this for a case study, but what I might do is we might go straight to talking about what trauma-informed care actually is. Look, I think it was really interesting looking at the results of the poll. I guess realizing that some of you feel more comfortable with using motivational interviewing, but I think the fact that a lot of you feeling a bit less certain about what to do with trauma-informed care probably also says a lot, because a lot of the people that we really would want to use motivational interviewing may have actually had, you know, some experiences which may be more challenging, which, you know, may make them more vulnerable. And these are the people where motivational interviewing may be a bit more interesting. I think one of the things that we probably recognise for trauma-informed care is, what does it actually mean when we talk about trauma-informed care? You know, I think it's a bit of a buzzword right at the moment, trauma-informed care, but a recognition about what we actually do about it probably means actually a recognition of what actually the effects of trauma are on the actual individual. And so I might bring us back to what does it actually mean about how a person might present with trauma. First of all, it's probably recognizing it's really common. The statistics are probably difficult for us to fully determine, but some, you know, most of our national statistics are really based on formal substantiation claims. So there's probably some underreporting which actually occurs, but we probably estimate probably about 12% of the population have probably experienced trauma. I guess I'm a GP, so I've also looked at kind of some of the data looking at how that actually presents in general practice as well. And, you know, if you actually look at some smaller studies, because unfortunately they are probably all smaller studies, some of the statistics probably look that possibly actually 1 in 3, which is pretty common, but 1 in 3 people have probably had an adverse childhood experience. And if we think about then those who present with symptoms, then due to their adverse childhood experience, it's probably about 1 in 4, which is actually pretty common.
Yeah, with that adverse child experience, I think it's important to recognise that that's a wide range of traumas. One of the ones that's really important is interpersonal trauma. So it's harm that comes to people, particularly as children, where the people that they trusted were neglectful or abusive, whether that be emotional, physical, sexual. So those interpersonal traumas are really important, but it can also be more general trauma as well, can't it? You know, you know, loss of a parent or a flood or a fire, those kinds of things. But they
or even
tend
just
not
having
to
a
have,
significant or
sorry,
even
yeah,
having a significant medical illness. You know,
yes,
think about those children who've had leukemia and they've been, you know, their trusted person has held them down against their will
mm,
to force
mm,
them to have treatments. I think our perception also about what trauma is, as
mm,
Hester was saying, I think sometimes we have these stigmas and judgments about what trauma
mm,
means.
absolutely.
Yeah.
And I think when I think about it in terms of the people that I see where trauma plays a big part, and this is a fantastic graph that shows you all the kind of experiences that people will have, is that quite often they're the ones that we experience negatively. So they're the ones who appear to be manipulative or avoidant or difficult or acting out or that kind of those when you're seeing those behaviours, it's kind of pretty much a dead cert that there's going to be some trauma there in the background. And certainly my experience in the group that I work with is that quite often that's a reason that they actually find it really difficult to access services or are denied services.
And
You
I
know,
think that's a really good point because, I think there is a lot of, and Hester, unfortunately, your group that you see, there is a significant amount of discrimination and stigma which occurs.
mm, mm,
But I think, to a varying extent, most of the patients that we see who've experienced trauma have experienced that at different levels.
mm,
And I was really excited that we actually had people who are joining us today from different specialties because I think, this may have occurred in lots of different situations where they may have experienced that trauma and discrimination. And I think one of the things that you talked about, Hester, is how people present.
mm,
And I think probably it's actually helpful for us to understand why they might present in
mm,
the way that they do, because I think then it helps us then work out how we're going to engage with them. So this wheel that I'm actually showing you is actually from an article that Associate Professor Louise Stone and myself published earlier this year. So if you want a summarization about everything I'm going to talk about trauma, you can look at the article as well. But I thought it's a useful illustration to talk about the symptoms which do occur for someone who presents with a background of trauma. In regards to this diagram, it was actually adapted from the International Society for Traumatic Stress Studies and also from the International Classification of Diseases 11th revision. So this is actually pretty new information, really in the last year or so, where they've actually considered the complexity of symptomatology that a person who's experienced trauma can present with. And I think that's really useful to know because I think previously our interpretations of someone who presents with trauma were really confusing because it is confusing. And so we didn't really have a unifying understanding of why a person who's experienced trauma presents in the way that they do. I think, first of all, it's probably useful to consider that there are some real neurobiological changes which actually occur when somebody's had an adverse event. And I think some people don't experience all these symptoms. We can talk about that a little bit later about what are protective mechanisms for why some people don't develop some of these symptoms. But, the more experiences that they have had which are adverse, the younger that they have been at the age when it's occurred, the more sense of helplessness that's occurred at the age that is, the more likely they are to have more of these symptoms, potentially all of these symptoms, and in greater severity. It's also probably useful to remember that not everyone presents with the same constellation of symptoms throughout all of their life course. So it might actually be that at certain triggering moments, that it might be more predominant that they're actually going to be manifesting in some of these symptoms. You know, it might be that it might be at particular times of stress or what might be stressful for them. So bearing in mind that different triggering experiences are different for the individual. It might be at, you know, particular life stages, which might occur as well. Or, you know, that might remind them about the thing which traumatized them. What we do notice is that if you can think about what happens in the brain when there's been a really stressful, overwhelming experience, is that the really primitive part of the brain, like the midbrain hippocampus area, which is a bit which controls stress and emotion, gets really stimulated when there's been an event which is very triggering. The other thing that that midbrain and amygdala area does is it's really important to manage kind of concentration and memory. So the problem is that if your brain's really stimulated with stress and anxiety, it might not be doing all the other functions that it needs to do. So often what you'll find is that people who've experienced very stressful experiences don't always remember the event very well. They may have really fragmented, confused memories, and sometimes that kind of comes back to them where they try to re-experience those memories, but in really unhelpful ways or ways which might be more traumatizing for them. And sometimes the confusing fragmentation of memory might also mean that they're not quite sure what they're also anxious and upset about, so they might be hypervigilant. So really anxious about something, but they can't quite work out why they're anxious about it, so it just doesn't really make sense as to why they're triggered or they're hypervigilant about what's going on. The other thing we probably notice is that for people who've really experienced very stressful events, if their amygdala and hippocampus is activated, sometimes the connections between that and your frontal cortex, so your thinking part of the brain, are often more affected. So if you actually look at functional MRIs, so images of people's brains for a person who's experienced extreme neglect compared to someone who hasn't, you'll actually notice the brains actually look different. So there's actually significant neuroatrophy in the images which actually occur. And so what you actually notice is someone who's experienced significant trauma may have difficulty regulating, being able to consciously control the emotions and feelings that they're actually getting. So I think if we recognize them, we can also recognize why it may also be difficult for them to then, if they're already feeling triggered, also get a handle when they are being triggered and they are being dysregulated. We also know that their attention and consciousness is often affected, which means they may not react as quickly as someone who hasn't experienced these events. You know, if you have someone who's experienced significant trauma and they're in a car and and they're about to go into a car accident, they might actually react several seconds slower and be more likely to have a car accident than someone who hasn't experienced trauma. They may also not always make the choices because it's more difficult for them to process those things because their attention is drawn away from some of the other intense emotions and sensations and feelings that they're having, which means some of their problem-solving capacity may also be limited as well. So you can also then recognize why sometimes then the initial traumas can be further compounded by other than difficult situations, which can be further traumatizing.
Yeah, and so certainly my thinking of the group of people that I see, look, you know, they're turning, not everyone, there's many reasons that people use substances, but in this group, the substances help them control their distress. It helps them to avoid their distress. It helps with their symptoms. And so it is, and it's one of the complicating things when you're working with someone around changing a behaviour, is that you've got to help them understand why that's there and the purpose that it has, and why people, when they come in and say, I just want to detox and then I'll be fine, it actually doesn't work, because you've taken something away which they've been using, and they've got to build skills to actually manage that space that's left behind.
That's so true. And I think that brings up a really important issue about avoidance, which is a really common way of coping that people who've experienced trauma have. And it's really interesting, because one of the things that has been shown to be really protective for people who've experienced adverse childhood events has actually been about there's a new concept of positive childhood experiences, and positive childhood experiences about strong, supportive, nurturing relationships, but also about achievements. And I think if you think about the way that children develop, children develop if you've got a safe, supportive network, they're allowed to explore, but you've got somewhere safe to come back to, and they learn to build up their achievements bit by bit. And avoidance is actually a really normal coping mechanism. It's a safe coping mechanism. If something's scary and devastating, just don't go near it. I think the only problem is that it can't be the only coping mechanism you use. And, if you've had that as your only coping mechanism and you've never felt safe to explore, it's going to continue to be the only coping mechanism that you have. And for some people, then they may use other ways to avoid those really difficult, challenging experiences, which, as Hester mentioned, sometimes is substance use, maybe gambling, maybe eating disorders. Eating disorders is very much linked to an avoidance behaviour. And interestingly enough, sometimes where you see those people where they're really, really calm, but then they have the explosive bouts of anger, often that's where they're suppressing a lot of their emotions until it just becomes no longer suppressible as well. For some people, part of, what they're experiencing, we have to remember that it's not just that neurobiological. I think that's an important aspect, but, most trauma, unfortunately, occurs due to somebody that they already know. So if you're thinking about your safe relationships, and your safe relationships have been the ones who have been involved in the traumatic experience, that's also going to often affect your belief systems and how you feel about yourselves. And children get magical thinking about why things happen, and so they may also attribute what's happened to things that they've done. If I was just better, this wouldn't have happened. And unfortunately, some of those things continue on, and it's often those hidden things which might be the schema as to why they're presenting in the way that they do. And we also have to remember the modeling of behaviours. There is a lot of how we learn how to engage with other people by how we see the relationships around us. And if the relationships around us have not been stable and supportive relationships, the modelling we're going to have is not necessarily going to be stable and supportive relationships, which might also mean that the subsequent relationships we look for are not always going to be stable and supportive relationships, which then compounds itself further as well. And so that explains why, somebody might present in the way that we have. And if we don't address all of those things, we're not looking at that whole person. We're not identifying why it's actually really hard for them to change, why they might be not choosing relationships which are supportive and safe for them, and why they feel it's too overwhelming to be able to take actions going forward. And I think also remembering that there is a lot of comorbidity. If you're feeling a lot of emotions, you're feeling really strong physical or emotional sensations, people might also present with somatic symptom disorder, with IBS, with, if you're a speech pathologist, you might be seeing globus hystericus, or you might be seeing tinnitus, or you might be seeing eating disorders, or you might be seeing not necessarily look after their health in other ways. So they might be presenting with ischemic heart disease. So, the way in which people present might actually be a number of different ways. It might be, as Hester mentioned, about how they might be presenting with substance use, or they might be, because that's your cohort, but actually it could actually just be the person who presents with, they're not really sure what's going on because they can't make sense of it. and they're just coming in a lot for it, but nothing seems to necessarily resolve it. So there might be a number of different ways that a person might actually present. And the other thing which you might notice on this slide is also what we might also do about that. I won't go into that because I think we're going to talk about motivational interviewing. But
I just wanted to ask, May, so in the middle of your donut, you've got complex post-traumatic stress disorder. Now, sometimes that is code, or can be, people talk about it, oh, that's borderline personality disorder. What are your thoughts about that?
Yeah, thanks for raising that. It's a really good question, and there's a lot of crossover, isn't there, about how people talk about people, and sometimes they just get this whole raft of diagnoses, don't they? Depression, anxiety, you know, borderline personality disorder, and there's so much stigma and discrimination about that term, isn't there?
Totally.
I think we really recognise borderline personality disorder really isn't a personality disorder in the sense of the same word. It probably is actually very much trauma related. So it's probably more accurate to call it like symptoms due to trauma. I think we also need to recognise that some people have complex post-traumatic stress disorder symptoms, but they don't necessarily have personality disorder. So they're not actually necessarily, you know, there is a lot of crossover with it, but they're not necessarily totally the same. So you might have somebody who, and in fact, there's been changes about our classifications about personality disorders. We're now talking about personality disorders now being defined in terms of just the severity of their personality disorder, and then you might further define it into type. But I think just bearing in mind, you know, you might have a person who's had complex post-traumatic stress disorder, but all they're manifesting is actually the issues about their belief system. So it's not causing a functional difficulty in terms of any of the other aspects. They wouldn't classify it as actually having a personality disorder. They've got symptoms, but they don't have a personality disorder.
Yeah. And I think the other thing is that many people will have adverse experiences, but as you were saying before, May, it's that balance. It's the severity of that adverse experience versus the protective factors. You know, so you will see people who have had extraordinarily adverse lives, but they've got a grandparent who is, you know, has always totally been there for them, or a teacher that was there for them at the right time, you know, or you know, so it's around, or they have a particular temperament where they just manage it better. You know, and so this is really this is humanness. And for me, I'm not greatly into the labels. I think it's about human experience and the effect that that has on a particular individual, and the harm and the distress and the way it interferes with them getting on and having the life that they want to have. It's really good to be able to, I think this is a brilliant donut to be looking at, and it's one that, depending on, you know, the person you're talking to, that you could actually use this to really describe and explain to them why they're having the experiences that they're having.
Yeah, I'd so agree with you. And so much of it is remembering that the person that we're seeing is a person and they've got their individual stories. And I think what often comes up for professionals seeing these people, and I think just remembering as part of those aspects which are helpful, is also those external supports like us. That's why we're having these conversations. But I think one of the things which can be really challenging is sometimes seeing a person, we forget that they're actually a person, that there are those individual stories, and there can be a sense that we're not doing enough, we're not fixing enough, where nothing's changing. But if you can actually look at all those things which are going on, sometimes what they're presenting with is actually the emotional distress, and they might be presenting with the emotional distress each time there's actually progress. And I think sometimes that's something which is not always seen. And being able to sit with that emotional distress and notice all these other things which are going, noticing with the story that they have that actually, oh, but they've formed another connection with somebody. It's still hard for them. They're still finding that really difficult. But actually, there's been some progress which has happened. It's just that as they're still progressing, it's still going to be really difficult and challenging for them. And we have to recognise that part of sitting on that journey with them is sitting with them throughout that distress as well.
And managing our own distress. And
managing our
understanding
own distress.
that this is likely to be a chronic issue that will change slowly over the time, but it does change. And we're in this terrific position in primary care where we do get to see people over time. And the real advantage that we have of knowing them, knowing the community, knowing their family, knowing their strengths, and helping them to actually, to begin to change that. And the connections that we have into counselling and support for them as well.
Yeah, completely understand. And I'd really recommend, as part of our sharing that distress, that we also recognise our own feelings and countertransference, how we get triggered in our own ways, and also make sure that we have our own strategies for managing that, which is why we're going to now be talking about that, and also that our organisations are supportive of us, and that we have things outside of our workplaces which also help support of that. And sometimes that also means mentoring and supervision and support as well. Yeah. So talking about then, what do we do? So I thought we might go back, and we're going to talk about motivational interviewing, but I thought I might also talk about when we might use it, because I think actually knowing how to use it is also really helpful. And so, sorry, I just clicked on the wrong thing. But look, I think one of the things we probably have to remember is that when somebody sees us, it can be really confusing when somebody sees us with trauma. So I probably just want us to then focus on what we are trying to achieve within a consultation. And part of the difficulty sometimes when you are seeing someone is actually the consultation itself. And I think if we're not sitting back and recognizing that, then we may be actually applying the wrong strategies for what's actually going on. So the way that I think about it is there a problem actually with the communication itself? And why is that happening? Because if they're not actually sure about what's going on, motivational interviewing may be a little bit trickier to do. Like, you might use it, you still can use it, but it's more about their development of understanding of things. So how you might target that might be a little bit different, compared to if they do know what's going on, but they're not quite sure how to then go about doing it, as opposed to they're not quite sure if they want to do it. So I thought that might just be helpful for us to start off with. And again, this is in the article, so you can have a further look at it. But then I think I'm conscious that you also are here because you want to hear about motivational interviewing. So on that note, shall we talk about that, Hester?
That sounds great.
So now let me remember where in the slides that we were for that. So
we need to go back.
Thank you. So excellent. I think, did you want us to start with the video, or do you want us to start with?
Let's have a look at the case, I reckon.
Excellent.
Yeah, so this is John, who's a 19-year-old. You see him in your practice because his girlfriend says she's worried about his drinking, and he explains he drinks on weekends and sometimes gets into fights when drunk. There have been a few times when he was so drunk he couldn't remember what he did the night before. Now, he says it's not really a problem, he can change it any time he wants. He enjoys drinking and hanging out with his mates. He says that school was never his thing, but he enjoyed doing his apprenticeship and now works in construction. So I know this is tricky because you guys are on mute, but if you wanted to just kind of put some thoughts into the chat, what are the issues that John brings up for you? What are the things that you're concerned about? How would you approach this? What are the little red flags that are coming up for you about John? And I know we have an issue that we can't see what you write until Lauren sends it across. So it'd be really great if you could get thinking about that. And I guess, May, while people are thinking about that and the chat's coming across to us, what are the things that are, in this case, which is one of mine, what are the things that you're noticing that you're concerned about?
Yeah, well, look, there's a few things here. One is, he hasn't necessarily come in because he wants to. He's come in because somebody else has identified a problem. And, you know, I guess what's the reason as to why then he still came in? Like, was it because she's basically said she's going to end the relationship if she doesn't come in? Has that actually highlighted something he was actually concerned about, and it's just given him an impetus to actually come in? You know, the other thing is that he, in terms of the issue at concern, the alcohol is really causing some considerable problems there. You know, this is something we're not ambivalent about. We want him to stop. So I think we do need to recognise that, you know, in regards to our aims about what we want to achieve, we have a particular ulterior motive here about what we want.
I wouldn't call it an ulterior motive. We have a particular kind of direction that we want to take this. I think.
Yeah, that's correct. And it's not ulterior, is it? It's pretty obvious for everyone. Yes.
So look, there's been a couple of things that people have said in the chat about, and the latest one is his relationship is important, but drinking fights memory is not an issue. That he's drinking to oblivion. He doesn't want to face it. He doesn't recognise it's a problem. He's not ready to change. He's not recognising it as a problem, whereas the people that it's an issue for the people he loves. I have to say that when I look at this, and it's very easy to look at this case and go, oh, he's pre-contemplative, he doesn't want to change. I think quite often the way you have this conversation can actually shift that. And it'd be really interesting to just investigate that a little bit with him. Absolutely, there will be times when, you know, very likely if you say, can we talk about this? Some more people will say, look, not today, or no, I really like it, I don't want to talk about it. That is possible. And you don't want to push against that resistance. And that's one of the core things about motivational interviewing, is rolling with the resistance. So you roll around it, you dance around it. And I guess what I'm thinking here is, you know, yes, you're right, May. His girlfriend has said, I'm worried about you. What does that actually mean for him? When he's been so drunk he couldn't remember what he did the night before. What is the outcome for him? Does that mean he's come to some harm? Have there been things that have happened? Has he drunk drive? Has he had an injury? You know, when somebody says to me, oh, it's not really a problem, I can change any time I want, immediately I'm thinking, oh, that's interesting. So tell me about that. So what else have we got in our chat? Just to make sure.
Another comment, peer pressure is not really encouraging him to stop. Need to find out what's important to him, mates, health, relationship. I thought the interesting comment was he's very young to drink that much, family history of alcoholism. I'm thinking, oh my gosh, I see lots of 19-year-olds.
Sorry, that's not that young. I mean, certainly when we look at the statistics, people are starting to drink in an older age. It used to be 14, now it's nearly 15. So we are seeing that change, and young people are actually drinking less. But about 35% of our community drink at unsafe levels. And we don't know if this guy has a little bit of dependency on the side there or not. But it's not uncommon. And we don't really know how much he's drinking, but he is drinking to blackout. And certainly he enjoys drinking and hanging out with his mates. One of the things that is interesting sometimes is, don't make the assumption that his mates are all doing the same behaviour. And there may be, in fact, some of his mates going, oh, why, John, you're just pushing it a bit hard, mate. We're a bit worried about you. Or it could be that they're all very heavy drinking. We just don't know. So it's looking at understanding a little bit more of what's going on. Should we go to the next slide?
I will. Oh, which is, do you want the next one about this topic rather than this case?
Yeah, let's, where did we put it? We've got to move around now.
Oh, I'll find it. Yep.
Fantastic. So, yeah, so John returned some weeks later. His girlfriend has encouraged him to come. He was arrested after a fight on the weekend. He broke somebody's jaw and is charged with assault. He's really worried about going to court, and he hasn't told his mum, as she knows she would be very upset. He notes that his dad, who's in the armed forces, gets really angry, and he was frightened of him when he was a child. He feels upset and remorseful and feels overwhelmed. Now, the good thing about the conversation that you as the GP, or I as the GP, had first time was that we opened up a conversation and he felt that it was okay to come back and see us. You know, there's many reasons why people don't talk about their drug and alcohol use to their doctors, and that can be from stigma and discrimination to shame to that's not medical. And what we've, you know, been able to set up in that first time we met John was, we're here to help, and he's come back. So, May, I just wanted to get a bit of a sense for you about this family Your thoughts
And
about this family?
yeah, and there's just also a really lovely comment as well. He shows he's just a bit interested because he agreed to come in. At least he values his relationship with his girlfriend.
Mm.
Or is she a really good nagger? Which is so, yeah.
Look, and sometimes the conversation, if somebody's got a family member that's harassing them, not harassing, nagging them to come in, it can be, okay, so you don't want to change your drinking, but you want to get your girlfriend off your back. What do you need to do to get your girlfriend off your back? And sometimes that can lead to some change in their other behaviour. But they're saying, no, the drinking's not an issue. Oh, but my girlfriend doesn't like it. I love my girlfriend. It's causing her problems. So maybe I can change it, but
Yeah.
it's once again, it's dancing around that.
Yeah,
But
and we've had other. Sorry, go on. I was going to say there's been other comments similarly saying his relationship's important, the drinks fight's memory is not an issue, and his drinking to oblivion. Is there something he does not wish to face?
Yeah.
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 Look, I have to say, thinking about that last comment about thinking that there's not something he wants to face, and your question about family, oh, well, maybe that's the thing he doesn't really want to face. And really, in terms of one, that he's come in because there is now potentially a legal issue which has happened, and that's not an uncommon thing. Sometimes people come in because there are court mandated reasons and they need to prove that they're engaging in therapy to not to go to jail. That's, that is a reason. I guess the other aspect then is that then the next step is he's having now difficulty talking to his mum about what's going on, which then begs the question, what is the reason as to why that's really difficult? This is going to be a pretty hard thing to hide, I would imagine. So at some point, he's 19, particularly if he's living at home, I imagine it'd be impossible to hide. If he's not living at home, possibly that's true, but then why is there this level of avoidance which is occurring about that? And there is the other issue about his father, which I think really is something that sends off some alarm bells there about whether there was some family violence which was occurring. And that's something where, look, we do need to be mindful. We don't need to always know the full story, because sometimes the retelling of the story can be re-traumatizing, and people are welcome to share what they're okay to share with. But I think actually just recognizing and making it really obvious that you're okay to listen if they want to share is a really important part of that process. And I think certainly saying that he was frightened of him when he was a child, he gets really angry. I think people who've been in the armed forces often have their own trauma to carry as well. And then when they come back home, then that can be really challenging. I think that's a really recognised issue which can occur. We've got a comment here from the panel about joining AA with standing well at court, and also let him know about legal aid. He needs as much practical assistance as well, which will help with his mental health relationship, and let him, and to be honest, I'd be confused about addressing the anxiety versus trauma versus original drinking reduction aid agenda. That's a really good comment for us to talk about. Hester.
Yeah, absolutely. Look, I think first of all, Alcoholics Anonymous is for people who have alcohol dependency. It has a particular approach that can be really useful for some people. We don't know if this young man has a dependency, and there would be some questions that we could ask him about that just to check that. I think one of the other things that happens is quite often there can be a thing of, well, he's only come for help because he wants to get out of, he's got the external driver of court. He doesn't really want to change. He's just being forced to by the courts. In my experience, this quite often is one of the really strong drivers, because you don't want anybody to go to jail. Jail is hideous. 19-year-old boy in jail. Oh my God. He's unlikely to go to jail for a fight on the weekend, but legal issues can be the thing that finally tips the balance for people. I need to do something about this. And it may be that once the court case is passed, then it all kind of settles down. He continues with the same behaviours. But it's a really great time to start supporting and helping him to do things differently. And certainly, yes, those letters of support and engaging him in treatment. And he may be someone who doesn't really want treatment, but you get him into treatment and then he realises the benefit. He realises that his girlfriend is much happier, that his mum and his dad are really supportive and want to support him to do this properly. And it can be a catalyst for very, very positive change. So I'm always looking for those hooks that can get people to engage in terms of doing things differently, but also being really clear around what it is that they want to do. So I'm just looking at a seatbelt comment.
Oh, I think that was talking about the consequences about jail, and you've kind of already responded to that one, Hester.
Yeah.
I'm just thinking about hooks. Should we start talking about what motivational interviewing is, Hester?
Totally. Why don't we go and look at the video? What do you reckon? Shall we look at the video?
Oh, I think the video would be a great idea.
How do you go, Lauren? Can you put the video for
Lauren,
us?
now, we're recognising for technical reasons, I'm going to stop sharing and Lauren's going to take it on here. So just bear with the lag as we go on and off from there.
Okay, are we back?
We're back. I love that video.
I just love it. All my sweaters are snagged. But look, it's that thing around for us looking from the outside. You can see for John, Jesus, you know, this amount of drinking, it's getting you into trouble. It is so easy to see it. So easy to see it from the outside. And we have this really strong writing reflex, which is around helping other people win. It's so easy from outside to see it. But that really lovely point in that video where he was able to stop talking about the nail and say to her, that must be really hard. And how automatically that changed the sense of the conversation and she felt heard. Did you want to say anything about that video?
Oh, it's kind of what we see all the time, isn't it? If you just stopped the alcohol, it's not about the alcohol. But yes, I guess one of the things though is when he picked that up, when he actually was able to engage, let's talk about then how we do that.
Mm-hmm. Exactly. So go to the right, find the right slide now, May.
We're here.
Okay, so motivational interviewing, for those of you who are not aware of it, is a directed patient-centered counselling style for eliciting behaviour change by helping the patient explore and resolve ambivalence. It is normal to be ambivalent. We are all ambivalent. It is patient-centered. It's about building efficacy of our patients, but it is directive. It's not supportive counselling. It actually has a goal, and that's looking at helping people to see how they can change, what they want to change, what they have the power to change, at the same time as affirming that it's up to them. So it's a really lovely, always when I'm thinking about it, it feels like a dance to me. And I've been doing this work for 25 years and I'm still learning how to do it. And I do it in all of my consultations. I do it when I'm talking to people about taking their medications, when I'm talking about exercise, when I'm talking about, you know, any kind of behavior. It is absolutely brilliant. The work originally was done by Rolnick and Miller. Miller's Australian, Rolnick is American. No, other way around. Rolnick is Australian and Miller was American.
Yeah, it's the other way around.
Who did a lot of work on smoking. And they've also applied it to alcohol. And it basically, any kind of behaviour where you're assisting people to think through changing behaviour is where motivational interviewing is absolutely gold.
And just a reminder as well, look, I think sometimes people get really scared off about the idea about using a psychological therapy because they think about it being, there's a lot to it, or that you have to engage the patient in a certain way. The whole purpose about motivational interviewing is that it's in an unstructured way. So you actually are just doing it all the time. And if you actually hear what Miller has spoken about this issue, the whole purpose about that is that in regards to how you how you might actually engage the person. It's not necessarily the techniques which add to the motivational interviewing. It's more these philosophical attributes in the style of the counsellor and the way that the actual counselling occurs, which makes it motivational interviewing. So the spirit of motivational interviewing really trumps the technique. And we'll talk a bit about the technique. But if there's anything you're going to take away from this, it's going to be about what the purpose of what we're trying to achieve is with motivational interviewing rather than necessarily the actual specific strategies.
Yeah, okay. Totally. And that other part of it is helping the person to sit in the ambivalence, to sit in the discomfort. And that comes back also to trauma-informed care. Because one of the things that can happen is people go, oh, no, I don't want to change it, because they don't feel like they can. And sitting in that space of, I really want this to be different and I can't, is emotionally really uncomfortable. And so helping people to build that strength and that sense of confidence around changing what it is that they want to change, and that may be very different to what I want them to change, you know. So but it is very much sitting with the person in that space and supporting them. And you may do this for 5 minutes once and then they'll go away and do it themselves. You know, people make changes all the time without us. The classic one that I often talk about is the woman that I had a brief chat about her doing other things. I had a brief chat about her risky alcohol use. And then I saw her 2 years later for something else. She went, oh, by the way, Hester, I thought about what you said after I left and I stopped drinking.
Like, I've had that happen. And you don't sometimes even remember even the interaction, but they've gone off and done it.
Yeah, and it's not as though I'm magic. I don't have any magic skill. They did the hard work, but I was a small kind of, you know, brick in that change that they were building for themselves, to, you know, and just giving them that little nudge. And the other thing about motivational interviewing is that people get nudges all over the place throughout their lives, and those nudges can push them away from change or can push them towards change. And so if all of us can nudge them towards change, that's a good thing.
Hester, the way the analogy I really like thinking about it, bearing in mind that everyone has a bit of ambivalence in themselves, we all also remember that kind of ambivalence we have in our own heads, where, you know, we go, should we do it? Should we not do it? but it's not like that conversation's not happening anyway. And just when we start talking to a person, we're just taking that conversation out into the real world. And sometimes when we have the conversations where we're telling them to do something, the automatic response in the head is, oh, but we shouldn't do that. Whereas if by motivational interviewing, and if we're doing it in the right way, the thing that they're leaving on is the ambivalence in their head, which is motivating them towards change. So that's why the invisible nature of what is going on is probably where the most work is that actually happens.
Totally, totally. And I think also that thing, you know, and for us, and once again, it comes back to the nail on the head, the wanting to fix things, that we can see what's wrong. And so we want to go straight to, right, you need to stop drinking. This is what you've got to do. And they're going, whoa, I haven't even got there yet. And so it can take a little longer if you just kind of sit back and sit with them in what's happening for them, but it speeds things up in the longer term. And I know the other thing for me as a young practitioner many years ago when I was young, that I would try, I could see it and I wanted to help people and I wanted them to change, and I would get hugely stressed at work because it wasn't working and what's wrong with me. And then I realized it wasn't up to me to change. It's not, it's neither here nor there. It's not my life. It's around supporting them to achieve what they want. And that's taken a huge amount of stress out of my life, I tell you. Really
I think we've all lived that, Hester. I so feel you when you say that. And it is that remembering of, you know, that it's that sitting with distress, you know, it's the sitting with distress and not fixing it, but actually realizing that by us sitting with that distress, actually that's moving them forward much more effectively. Particularly because a lot of these people have been so disempowered and they've been sitting and living with distress. So, you know, us sharing that journey is actually just us sharing the journey, but it's their distress, it's their suffering, and we're helping them probably just in that journey by sharing some of that journey. And that's sometimes that empowerment of that is sometimes the thing which kind of moves them along, particularly when they've also often been so disempowered. So even if it's small changes like them being able to make a choice, that's often incredibly important.
Absolutely. Absolutely.
So
what's the next page? I've forgotten.
I was thinking that. Yeah. Beautiful. We've just talked about some of this. So.
We have. And look, these are kind of core things that come up for us. This person doesn't want to change. They're not interested in change. Their health is the most important thing to them. That's quite often not the case. And you just have a look at our society. What do we spend our money on in our society to think about what's actually important? The tough approach is always best. Just tell them how it is. If you don't stop drinking, you're going to die. It doesn't really work. I'm the expert. I know what you need to do. Just follow my advice. You know, they don't particularly work that well. You may get some people who come to you and say, May, just tell me what to do and I'll do it, in which case they're inviting you to give your expert opinion. But generally people don't want to do that. But that doesn't mean you can't give them information. And it doesn't mean you can't say to them, look, I've seen people with this issue before and what's helped them has been this and this and this. Could that help you? You know, it's about opening up that conversation, but allowing them to go, no, Hester, that's not going to work. Doesn't work for me. Okay, well, what would? You know, rather than coming up with quick and got to get there and get to the end of it and diagnose it and get it fixed, because these things take time. And you may well have people that continue in the behaviours that you're concerned about. How can you help them to do it less harmfully? Is the other really important change.
Because if we think about the advice, and I think that can be tricky when we also have the professional hat on as well as the counselling hat on, where you're not a content expert, but when you're a content expert as well, the advice is about giving enough information to empower them to make a rational choice, but it's not about us making the choice for them or telling them what we would do about it.
Yep, totally. So, all right, next page.
Fun.
Exciting. I don't know what's coming next. Okay, so the stage of change, I think we've talked about this a little bit, you know, this idea that there's pre-contemplative and contemplative and preparing for action and then maintenance. It's never that simple. And the way that you have the conversation and the way that the things that happen in a person's day can actually fling them from one to the other. And so motivational interviewing, if somebody comes into you and says, right, I'm ready to stop smoking, I want the patches, and I've already signed up to quit line, then you're not going to need to do no motivational interviewing. They're already in there. They're already ready for action. But it is at that point important just flag with them, that's really, really brilliant. You know, let's get this going. How are you going to manage if you have a lapse? You know, and preparing them for the possibility that it might not be as easy as they think, or it may be, but you're there to support them with whatever they need. And it is an ongoing spiral, you know, and so you just got to think about the number of people who join the gym and as part of their New Year's resolution. Do you know how many weeks the majority of people go to the gym after joining it at New Year's? What do you reckon, May? How many weeks do they go for?
Oh, look, I'm sure many don't even make it there at all. So, yes.
The average is 2 weeks.
Yes.
And then you go back to work and then life gets busy. Gyms they survive on all those people that have New Year's resolutions.
New Year's resolutions.
And then don't get around to cancelling it. You know, because change is tricky and we will slip back. And that's, you know, that's part of that dance of making change. And you'll have a time when you're doing it very well, when you're eating well, when you're exercising well, when you've stopped the smoking, and then things can happen and you start again. And so it is understanding that this is an ongoing issue for all of us, no matter what the behaviour is.
Yeah. And remembering that motivational interviewing is not actually stages of change. It's recognising that actually the ambivalence is present all the time at any stage.
Yep.
So I think what we are trying to do is recognising that actually there are things we can do at any stage,
Totally.
at any point of time.
At any point. Yeah.
Yeah. So,
cool.
So the next bits were about really.
We've been there.
Yep.
Yeah.
Been there. So this is back to John, but I was wondering, should we talk a little bit now about some of the, I wonder whether we should talk about some of the things and then go back to John, or?
Yeah, for sure.
Yeah.
For sure.
So
one of the problems with having one case and we're bringing up new issues is you kind of think, oh, geez, none of the things I did worked. Okay, but I'll leave it at that. Go for it, May.
Yeah. So look, I think it is probably helpful for us. I did say that, you know, it's more about the attitude rather than the skills, but I think we should talk about some of the skills.
Totally.
And the reason why you've got this picture here is because a good old acronym for the motivational interviewing skills is OARS, and that stands for open-ended questions, affirming, reflecting, summarizing. So I think it's helpful to just bear in mind, bear in mind that I think some of us are probably going to be more familiar with open-ended questions, you know, making sure that, you know, we're allowing them to talk about things. If you actually look at what's probably most effective in motivational interviewing, it's actually affirmations. I'm not sure if you know what affirmations are. I'm happy to get some feedback or in the chats or things. But affirmations are really, like in that video, just having an acknowledgement.
That must be really hard for you.
That must be really hard for you.
Yeah.
It might not even be verbal. It could be just a non-verbal, or it could be just a listening face. But if you actually look at the most effective, if we are looking at techniques, but the most effective strategies, if you do at least twice as many affirmations as anything else, it is much more effective than interrupting them with lots of open-ended questions, which I think is something which is really hard for people to get used to.
Yeah. And silence and giving space. Now, you know, and there's times in consultations where I have to go, shut up, Hester, shut up, Hester, shut up, Hester. You know, sit on my hands, because I know that there's some gold there that they're just kind of thinking about, and it's going to, you know, and if I interrupt, that'll be gone. And you know, that comes back to the whole thing of the anxiety that we feel around, you know, moving things along, and silence.
Yeah, silence
it's
can
really
feel really
hard.
awkward. Yeah, but sometimes the silence is really telling. And you know, some of my most successful consultations where a lot has happened is sometimes just waiting. and just waiting for that silence. And sometimes when there's lots of silences, it's about recognizing, I noticed that was hard for you to come up with a response to that. What was happening there? And then you can actually recognize what's also triggering for the person. So listening to that space, being in that space is actually really important. And I make it a real habit that when a person comes in, particularly a new person I've not met before, I just let them talk. I just let them talk until they completely stop, because those are the things which are really burning for them. And then if it doesn't make sense, then I can try to work out what else is going on. But that initial story which comes out, that's the bit that we're generally working with.
And once the story comes out, then it's around using reflection and summarising. And that they're really important too, because what they tell the person is that you've heard, and that you're trying to understand. So, yep.
No, go on, Hester. You were about.
Yeah. So no, you're right. You're right. It's difficult in this online space. We don't always get all the cues. But summarising, just want to understand. Have I understood what you've told me? And it's a chance to check in so that they can make sure that you've understood, and that sense of being heard and of being understood. Reflecting, you can use different ways of doing that, but it's for me in reflecting, it's really kind of keeping a bit of an eye on the change statements that they're making, and that's one thing that we do want to really make sure that you guys have a bit of a think about going away from this session, because they're gold in terms of assisting people to make change.
I would make a further comment about reflections. It's not just reflections where you just repeat what they say. No. It's actually reflections where it's what we call complex reflections. So where we've actually really listened to what they've said and reflected back and added more to that. So a good example might be like with that nail in the head story. It could be, that sounds really hard. So you're telling me that it's been really challenging for you. You're having difficulty sleeping. There's something which is snagging your clothes, and it's a really awful experience for you, but you're feeling that everyone keeps remarking about this nail in your head, and that's really frustrating for you. That's a complex reflection. So I think the other comments here is that this goes back to the whole spirit of motivational interviewing. We can't just do these strategies and just do them. We really have to do them with the whole process where we're aiming to engage the person and we're supporting self-efficiency. We're not the ones coming up with the answers. We're just helping them with them resolving their ambivalence to where they want to go with that.
Absolutely.
So we should talk about change statements, because I'm conscious of time and I want us to be able to get to this. So Hester, do you want to?
So this
do you want me to?
Change. No, I'll go for it. What you're looking for is anything that suggests that where they are now is not where they want to be. So they may talk about, oh look, I really like my drinking, but it really upsets my girlfriend and I don't like that. I know, look, sometimes when I drink, I just don't perform as well at work, and I really like my work in construction. I'm really hoping to get a promotion. And optimism about change. I think I could do this. I think I might have a go. Or look, I've tried this before in the past, and and that's one of the things with John saying, oh look, I could change it if I wanted to. So have you tried before in the past and what worked? And expressing intention to change. I've been thinking about this. This is important. My girlfriend doesn't like it. I'd really like to do it differently. I'm just not sure how. Might be some of the statements that you kind of are looking for, and then you hone in on those and amplify those. And any of the ones that are about maintaining the status quo, you kind of leave those well alone and go for the ones where there's some room for move. for movement.
And it seems very counterintuitive, because I think we listen for the sustained stories because those are the ones we're primed to listen to. But if you focus on them too much, it actually makes the process really inefficient.
Yeah.
I think because we're also taught to empathize, and by empathizing, we're often taught to empathize with the sustained talk, but it's actually that by doing that too much, we don't actually move forward. Like, it's okay to recognize that. You can do that in the complex reflections, but you can't have that the main focus of what you're talking about. You want to listen out for those nuggets of change to move things along. And if you can do that in that way, you'll actually find that using motivational interviewing will actually become much more efficient for you in the consultation.
Yeah, absolutely. I'm just reading what somebody wrote in here. You know, the world is such a critical place, including human nature, that it's not often that we get positive feedback. So reflecting back some positive attributes to the person is a good thing. Of course, it needs to be a genuine reflection of their values. Absolutely. And it might be that when what your positive reflections that you're reflecting back might be, you are such a survivor. You are so tough. You managed that being homeless for the last 3 weeks. Oh my goodness, you are so strong. You know, so it's looking for the strengths that they have that may be very outside our experience or not directly related to the behaviour that you're wanting to help them to change or that they're wanting to change, but that actually is a strength for them.
And I think we often forget how resilient they are.
Totally, totally.
Yeah.
We've got a few pages here which are kind of looking at change statements, haven't we? Is that?
We do. I think we would like to hear your thoughts on what a change talk in here. So please feel free to put that in the chat.
Look, Doc, I know I should stop drinking, but I really love it. Drinking with my mates is fun, and my uncle drank a bottle of whiskey a night and lived till he was 98. Is there any change talk in this one? Can anybody see any? When you look at this kind of looks like classic pre-contemplative, but May, what do you reckon?
I know I should stop drinking.
Exactly. What's that about? What is that about? You know, and is there an internal driver there for actually, I don't really like this. I don't really like the way it makes me feel in the mornings. We don't know.
And sometimes all I say to them is I actually say, so, and I actually just repeat it back. I say, so you said, I know I should stop drinking. And then I just leave it. And then they'll talk about that.
Exactly. Let's try the next one. Look, Doc, I've been thinking about drinking and I've decided that I need to do this now. What do people think about that one? Where's the change talk there? It's a bit slow with the messages, isn't it? Sorry, guys.
There's two parts of change talk there, aren't there?
Yeah. What do you reckon, mate?
Yeah, so he's been thinking about it. It's obviously been on his mind about what's been going on. But he also wants to take action now. That's really positive. That one, that he's been contemplating this for a while, you know, potentially a while, and now he's also determined to take action.
But I'm interested in what the this is. What does this mean? Yeah. So I can't assume. Oh, we've got some
responses here. So is there another way to have fun with mates?
Yeah.
Contemplative. Tell me a bit more. Oh, I love that. Tell me a bit more. That would be a great response to that.
Yes. Yeah. Totally.
Open-ended question.
Yeah.
Yeah. Oh.
Yeah. Fantastic. Let's try another one. Look, Doc, my wife is concerned about my drinking. I know it upsets her, but I really like it. I'm not sure if I want to change. What do people think about that one? I mean, this is very similar to John with his girlfriend saying that she's concerned. And it's really common for people to really like it. I really like Tim Tams. And, you know, I know that there are 11 in a packet. I shouldn't eat the whole packet. I really shouldn't. But they taste so good, you know. It's normal. This is normal ambivalence. And once again, that's normal ambivalence. But where is the change statement and where is the room to actually really get that person thinking about what might they want to be different?
And just bear in mind, again, there are 2 change statements here. So
Mm.
I'd love to hear both of them come out.
Mm-hmm. Mm-hmm. Okay, let's go on to the next one. There's one more, isn't there?
Did you want to talk about what the change statements here first?
I thought we'd done that.
No, we haven't yet. So here, wife needs to attend, Al-Anon for clues as to how to behave. Okay. That might be another thing to discuss for the wife. I think it is also important to remember who's in the room at the moment, because at this point of time, the person in the room is your patient. But yes, if you were seeing both, then you'd talk about what you do next. Here, your wife is concerned about you drinking. You're not sure you want to change. I love that. Beautiful. So that's continuing on. It's affirmation about both those change statements, and I love that you picked up both. Well done.
Yeah, and it's, you're not making any assumptions there. You're actually reflecting back what Joe has said.
Yeah.
And when Joe hears that, he goes, oh, okay. Maybe I need to think about this. Next one. Look, Doc, my wife is concerned. Oh, no. Look, Doc, I used to drink a lot when I was younger. I've changed this and for a long time been abstinent. However, recently I've been thinking about drinking again.
This is a bit of a tricky one, isn't it?
It is, and it is. I have to say, and look, and Al-Anon and AA and Alteen, which are the abstinence-based 12-step programs for people who have alcohol issues, their families and their children, can be really, really useful. It's not uncommon, though, that people find it really hard to consider never having a drink again, never undertaking that behaviour again, and very commonly that they want to just get it under control. They want to go back to controlled drinking. There are a group of people where it becomes clear for them over time that that actually doesn't work for them. And it may well be that Joe is someone where alcohol is too destructive, too difficult, he cannot manage it and he needs to remain abstinent. But it's very common for people to want to have a drink occasionally, and they can be very fearful that all the problems that they had will come back, and that's not always the case. But this is a really nice space to be talking about what the concerns are and how, so someone's saying, tell me about the times when you used to drink a lot. What did that mean?
Yeah, beautiful.
Absolutely.
And I think that's really good, because what you're trying to work out is you're actually trying to find out more about this, which I think goes into what do we do if we're not quite sure if it's change talk there. There possibly was a little bit there in that he's going that he has changed. And it sounds that, tell me more about the times when you used to drink a lot. Tell me more about then what it's been like when you haven't been drinking. What's different about that?
That's right.
So that's how you might actually elucidate what works for this person as to why they would want to continue to not drink. And part of that is recognising their motivation, and part of that's recognising how important it is for them to continue not to drink and how confident they are that they can change. And they are different. I think sometimes when we talk about motivation, we lump it all in the same basket. Sometimes people really want to change, but they're not quite sure how to do it. So I'm just conscious about time, so I might just move on to the next one.
Yep. So this is, I think it's got some little arrows that come up if you click. This just once again states what you were saying, May. If something's really important to you and you're really confident you can change, that's great. If something's really not important to you but you could change at any time, you're probably not going to change it. If it's really important and your confidence is really low, this is really important for me to change and I can't change it. That's, as we said before, that's a really tricky emotional place to be. And what you need to do for that person is help them to find ways to build their confidence. If you're there, what else have we got? High confidence, high importance, low confidence, low importance. Those are not going to change. Sorry, moving on. And then one of the nice ways, and with many of my patients this is very, very useful, is
I use this a lot as well. Yeah.
People quite like the numbers. On a scale of 1 to 10, how important is it for you to change this particular thing that you want to change. You've got to flag, first of all, you've got to find out what it is. And it might be, I want to change from drinking 10 schooners to 5 schooners. Yeah, that might not be what my ultimate goal is, but that might be what they want to change. How important is it for you? And if they say 1 out of 10, it's not that important. If they say 7 out of 10, it's pretty important, and it's a place that you can work with. If they do say something lower than 7, one of the things I'll say is, so if they say, oh, it's 3 out of 10, and this is particularly for confidence, I have to say, look, my confidence is 3 out of 10. Why is it so high? That then, because you're looking for in that 3 out of 10, where are their strengths that they perceive? So once again, it's that counterintuitive. 3 out of 10. Why is it so high? What's going on there? And they go, what? Yeah. Tell me about the things that you do have. You do think you can do.
And you're using it as a motivational tool, aren't you? Because you're actually asking them to have that dialogue into their head about why it's important, about why it's confident. And so the question is actually a trigger for it. I mean, in actual fact, we don't necessarily need to know all the answers. We just need them to be thinking about it.
Exactly.
So you can ask those questions about, why is it so high? You can ask what makes it a 3 as opposed to a 1. But that follow-up question is actually the motivating agent.
Absolutely. Cool.
So I'm conscious we have next one here. I'm just conscious we have about 7 minutes left, by the way, Hester. So
yeah. So look, I really like the pros and cons, and I would always do it in a 4 table where I go, what are the good things about continuing the behaviour? What are the good things about stopping the behaviour? What are the not so good things about continuing the behaviour? And what are the not so good things about stopping the behaviour? And that may sound like we're kind of doubling up, but quite often you'll get subtly different things. And you might get, a huge long list of all the things, the reasons why they think they should change the behaviour. And one thing, which is the sustaining thing, this is why it's good to do this. And that one thing may be the most important. Or it may be that they look at that huge list and they go, well, quite clearly, I'm looking at this list. There's all these things. I hadn't thought this through. One of the things about ambivalence, and it is one of the nice things about getting this out and getting them to think it out, whether it's on a bit of paper or verbally or whatever mode suits them, is that it really helps them to work through that ambivalence and to really start to sit in it and think about it and start doing some, just to sort it, because it can all be a big confusion that doesn't feel very, very good. And so putting it out there just really helps them to think about it. And then you can say after that, well, where does that leave you now? And it may well be for our John, my girlfriend is really important to me. It really upsets her. I hate it when I upset her. I really like my mates, but you know what? She's my priority. And I can see from doing this how important that is. I can't believe I didn't really see that. I always knew it, but yeah, okay. This is what's important for me.
We had a comment that it's a bit like push-pulling.
Yes.
Push-pulling, yes.
Push-pulling,
yeah.
Totally.
I think just continuing on what you were saying though, Hester, I think the other thing when you're doing a table like this is that the pros and cons also have to be very values linked. So it's not just that you're writing it down, but sometimes the discussion about it and the exploration of them actually makes them really think about what's also important for them as well.
Absolutely. And just thinking of, for our John who's saying his girlfriend is important, it's about that value of what makes a good man is being in a relationship, is being kind to the person that they're in relationship with, or whatever it is. But you're absolutely right, because you're looking for those internal drivers. What is important? What is core to that person's sense of themselves, of what's important? And so looking to amplify those, because that's where the gold lies, and that's what they want to have in their lives, and really working with them to really bring those out and help them achieve that.
Yeah.
Yeah. So we've kind of done that. Once again, coming back to summarising and helping the person. Yeah. So querying extremes is a really nice way of working with ambivalence as well. Just moving on to the next slide there, May. What could be the worst that happened if you change or don't change? What could be the best that could happen if you change or don't change? Where would you like to be in 10 years' time? What would this look like if you didn't change in 10 years' time? Really looking through, just getting them to think about what could be different and to imagine. And a really important thing for me in those conversations is a message of hope from me around the possibility of change, the possibility of things improving, particularly for the group of people that I work with that have such adversity.
I think also the other thing which can come in the way of this often keeps coming back to confidence, because sometimes when we're working with this particular group of people, if we're talking about trauma-informed care, it's not like it's not important with them, but it can be just so overwhelming for them.
Absolutely.
That it's not like they can't even conceive of what it's like. And bear in mind, every time that there is a change which is happening, a transition which is happening, and the reason we're doing motivational interviewing is we're looking at some sort of ambivalence, their distress regulation will be really triggered.
Exactly.
So I think it's important to recognise that part of the process of the motivational interviewing is sitting with that really just uncomfortable emotion at the same time, and that reminder that at the same time as the motivational interview, we most commonly are also doing distress regulation at the same time. You know, I can see it's really hard for you even talking about this at the moment. You know, when you've been upset like this, what things have you found helpful? And sometimes it might be alcohol. Oh, okay, so that's a bit of a problem then. So you know, even thinking about stopping alcohol makes you want to drink alcohol.
Exactly.
You know, that's
exactly.
So then you might also be exploring what other strategies they might do. You know, what other things have you ever done in the past that you could do? You know,
absolutely. Absolutely. All right, so we've got 2 minutes left, so we better kind of summarise.
I know.
We've done the looking forward, past successes, internal drivers. We've spoken about that as well.
Yep. This is our summary.
Yeah, look, I really hope that you guys have found our conversation this evening useful. And I have to say, Sue, that just once again, you know, your graphs there, particularly the donut, beautiful, really nice pictorial way of looking at that. And it's just that thing of really helping us to understand the background that people bring into the consultation, and that can take time to understand, and we may never fully understand it, and in a way that doesn't matter. But it's really understanding that there is complexity and that people are extraordinary and can make changes. And with our support, which is around respect and boundaries and curiosity, that we can actually help them to make real change.
And we had a question here about how do you manage silence on telehealth as you can't see them, and I think we do remember with COVID we're doing a lot of that at the moment. I personally find it's really hard to have a consultation about psychological issues without seeing the person, because so much gets lost non-verbally. But you know, I certainly have had those conversations, and sometimes I'll just comment on them. I'll just go, oh, you're very quiet there, what's going on there?
Look, I think sometimes it's interesting in terms of telehealth, and if you've got the video, that's kind of nice, though it is a bit different. But it's also that sometimes on the telephone, you hear things that you don't hear when you're in the same room. And so there's different, it is different, and the way that you respond, because your perceptions are going to be different. And so actually I found sometimes it is quite useful, particularly for people that I know well, that I'm starting to hear things differently because I don't have those visual cues, particularly for someone that I know well, that I know how they present.
I think that mostly works though for someone you know well though, Hester.
Exactly. Yeah. Exactly. It's much harder if you don't know them.
Yeah. And for those of you who do want to learn a little bit more about motivational interviewing, I know we did do a snapshot, and Hester and I were talking about, you know, we run like full-day workshops and motivational interviewing, so there was a lot we were cramming in to 1.5 hours. But if you do want to know more, I would suggest that you look at the 3rd edition, and there have been like motivational interviewing has changed a lot over the years. So I would bear in mind that if you are looking up information, that it is current.
Absolutely.
I would really recommend that you actually have a look through this book as well.
Yeah.
So,
Yeah.
oh gosh, we finish at 8:31, but yes. So
Well,
I'm
thanks.
really happy to be contacted with any questions. You know, I'm pretty approachable, and Hester, I imagine, same. But
Absolutely.
but look, I agree. I hope this has really been helpful. And as I said, you're not going to get the whole snapshot of motivational interviewing, but even if you can just get the principles of motivational interviewing and just be able to pick up those nuggets of change talk, I think that really just starts you off on a really good.
Totally. And remember, you're not the one that has to change it. It's the people that your clients or patients that you're seeing, and it's around working with where they're at. And it's okay. It's okay for it to take some time and for it not to all be solved. And they'll go away and do it in their own time anyway, because it's their lives.
Yeah, that's very true.
Fantastic. Okay, guys, thank you so much for your time. Have a great night. Look after yourselves. Be safe and sane, hey?